All right, next section, examination.
But we start from the beginning, right? The beginning is, do we have reason to do this? So that's the evidence basis behind what we're doing. You've got to do everything with the medical model, right? The medical model of treatment. You must have a reason, a presenting complaint. You must have a concept of, do I have what it takes to help this family, right? Am I qualified? Is there reason? What do we find in the history? What do we find in the evaluation? What's our provisional diagnosis, differential diagnosis? What tests do we organize? Then how do we analyze and evaluate those test results along with our clinical findings? How do we set goals once we have diagnosed the problem? And after we've diagnosed the problem and set the goals, we orchestrate a treatment plan. And then we present that treatment plan. And then the parents will give consent to that treatment plan or change if they don't. And then we execute that treatment plan. And then we reevaluate mid-treatment or early treatment. And then we represent our findings. And then we reach the maximum medical intervention. And then we're done. Or we refer onwards, or we maintain and retain. All right, so this is the medical model. It is a well-established formula, which we as dentists tend to shortcut, right? Patient walks through the door, we find out what their name is, we see the hole, we fill the hole, we give them the bill. Yeah? That's the dental model. Well, we can't use that particular model. We have to use the medical model. We screen for airway. Medical history, right? We're taking a medical history. Allergies, previous illnesses, congenital issues, health issues, medications, airway issues. How do we screen? Chevron in 2000 created a pediatric sleep questionnaire. This should be part of every medical intake form in every practice throughout the world. It's a very efficient way of screening for sleep disorder breathing without needing a sleep study. It's over 80% specificity and sensitivity level. It's just a simple questionnaire that the parents fill out, and it helps you understand, are there issues with their nighttime breathing? Are there issues with their daytime breathing? Are there issues with their daytime concentration? So we know sleep disorder breathing and ADHD, they're all kind of intertwined. So we need to know, is this ADHD? Is this sleep disorder breathing? Is this a daytime only issue? Is this a nighttime issue only? Or is it all? All right, very simple, takes 5 minutes, opens up a whole universe of eligible, qualified patients for you to send off for medical evaluation or for you to send into your orthodontic records department. We can do a clinical exam that has been validated by sleep physicians. Villa created a sleep physician clinical exam, which happens to be mostly an orthodontic evaluation. All right. They fill out this form when they don't have access to sleep studies. Guess what? We can fill this form out too. Because we don't have a sleep study in the back room of our clinic, do we? But we can print this out on our printer and we can fill it out in our clinic. It's just an orthodontic exam with a little bit of an ENT exam. So I'm going to teach you how to do that. You can plug it into the formula, and then you can have a valid reason to refer to the sleep physician because you've done the homework for them, because that's all they're going to do. And you can now work in collaboration with ENTs and sleep physicians. So what are the orthodontic clues? The profile tells you everything. We know there's less issues when it's class 1. It's frozen. Adriana, it's kind of all frozen up. Okay. We know there are more problems associated with Division 1 Class 2 malocclusions. So learn to recognize it. We know Division 2 is no different to Division 1, Pancherez, 1997, other than the inclination of the incisors. Learn to read the face, learn to read the occlusion. See, as dentists, we tend to look above with our mirror. All right, if you want to do orthodontic intervention, you've got to start looking at profiles because that tells you what's happening. Above with the mirror just tells you what's happening with each tooth. High angle have the biggest issues. High angle cases have the biggest health issues. Vertical growth drives the tongue into the back of the throat, which is why they stick it out between their front teeth. And no tongue tamers driving that tongue back is going to work because air is more important than a little pain. They're not hanging their mouth open, breathing through their mouth because they've got nothing better to do. It's because they can't close their mouth and breathe through their nose. The sleep physicians know to look for high palates and narrow arches. They know this. It's validated history taking. And they are looking for cross bites. Guess what we can look for? They're looking for the widths. You need a minimum width in order to get everything to fit, right? When you're not wide enough, you can't fit your tongue on the palate. And the tongue starts to drop. And then you get the tongue influencing the mandible more than it influences the maxilla. So you get a divergence of the growth. It's very easy to see the extremes. In general practice, you never see them. These are all handled by the specialist clinics at the children's. But they're looking for the same things, just more extreme. But they come see me when they're at the milder end of the extremes. And they're not eligible for surgery because it's the extreme ones that get all the attention. So they're lost in that system. So it's up to us to help. A lot of syndromic children, a lot of autistic children on the spectrum, they end up in normal practice. They're not so bad that, they're high functioning, right? They're not so bad they need absolute only specialist care. And they're the ones who really need your help because they're the ones who tend to have the breathing issues. When you look in the mouth, you want to see a hole. You don't want to see just tongue. Because that's our nightmare too, right? How nice would dentistry be without a tongue? When you have a child or an adult open, you need to see a hole. When you don't see a hole, there's a problem. All right, open, wide, you should be able to see the back of the pharynx. The tongue should have mobility. It doesn't work as well if it's tethered down. So there's simple ways of screening. It's every 4 millimeters, right? 4 millimeters, 4 millimeters, 4 millimeters. If the tether is right at the tip, if the tether is 16 mils back, 8 mils back, 12 mils back, 4 mils back, that's how you classify it. The tonsils. Now, normally the tonsils are just the neighborhood behind where we operate, yeah? But guess what? We can see them. But again, here's the secret. When you ask a child to say R and open, you need to see a hole. And I don't mean that, all right? I don't mean this. This is not a hole. It's a teeny tiny triangle. And you need to recognize this. But how many of us look? How many of us look? What are the radiographic clues? Well, you can actually see a lot with the lateral ceph, and you can see a lot with an OPG, right? The Panax X-ray. Obstructive sleep apnea, the children have very specific facial forms, high angle cases as a general rule. When we take a ceph, we can figure out the FMA, the angle of divergence. We can see the adenoids. We can see the tonsils sometimes if they're big. We can see the hard palate and the soft palate. We can see where the hyoid bone is. Because these are all clues accepted into medical literature. We can see where the tongue is resting. We can see the top of the tongue. Right? Huge clues that are ever present in our radiographs. And you can use this enough to screen for appropriate qualified referrals. After treatment, you want to see a bigger hole. Then you know you're on the right track, right? Do you want to see a smaller hole when you're done? Like, the teeth might look better, but what if you've compromised vital health? Like, if the teeth don't fit and you pull them out, and then you pull the incisors back to close up all the spaces, have you made more tongue space or less tongue space? And if you've got less tongue space in the mouth, where will it live? Right, either in the back of the throat or out between the front teeth. CBCTs help us, but we know that we can't judge airway. We can judge airway volume, but we don't know the dynamic changes that occur at night. All right, so it's really important to understand that. You need sleep endoscopy. to be able to see whether there's collapsibility. Right? I'd rather have a teeny tiny airway that doesn't collapse than an enormous airway that flattens the moment I go to sleep. So some people take a lot of cone beam x-rays, and there's a huge amount of information. All right, so let me counsel you. If you take cone beam x-rays, get a radiologist to sign off the report, because every x-ray we take, whether it be cone beam or 2D, we're entirely responsible for the findings. So if you miss anything, you have to explain it to the dental board, King's Council. All right, we can see where the tongue lives. We can see all the bits and pieces. If you're going to do this, you have to play at the same level as the big boys and the big girls who practice orthodontics professionally. You need to take proper records. You need to take photos that meet standard of care. You need to have information that is clearly usable for diagnostics. You need to be able to justify what you're doing by tracing and analyzing lateral ceph. You cannot practice orthodontics without taking x-rays and having them analyzed. All right. If you don't take lateral cephs and have them analyzed for diagnosis of the skeletal base, then you are not meeting the standard of care, and you will not have a leg to stand on. It is called unsafe practice. You must have a ceph analysis. You must have records that are better than the orthodontist. You want to practice safe dentistry? Be better than the specialists. It's not that hard. It's not that hard, because the specialists have their staff take all the records. You take the records and you be better than their nurses. Do you think you could do that? Because if you don't think you can do that, don't practice ortho, because it's not safe for you. You must be able to, at a glance, show that you are as good as the specialist in records. Because that's what your lawyer will ask you. Can you show me your records? And if they look like a dog's breakfast, they'll say, let's see if we can settle. If they look at your records and they're better than standard of care, they'll say, well, okay, let's talk about how we can defend you. And when I talk about settle, I'm talking about your license will be restricted so you can't practice ortho anymore. You know that, right? Unless you're supervised by a real orthodontist, where you have to submit all your records to them for approval. That's how the system works for general dentists who are hauled up in front of a board. You need to use your records to explain it to yourself and to the parents. You have to talk the lingo. When we talk about all the cephalometric numbers and angles and measurement, you need to understand it. You need to do your homework. You need to trace yourself or have a service do it for you, and you have to understand the findings so that you can explain it to the King's Counsel who's cross-examining you. They'll want the answer, is he working outside of his scope of practice? If you don't have orthodontic records at the minimum standard of care, then you are working outside of your scope of practice, your scope of competency. Because unless you have records, you cannot diagnose. You cannot diagnose. And diagnosis is the secret to success. Okay, so end of examination, Ken.
All right, terrific. So it is,
And we're back on time.
we're just 3 minutes over. Fantastic. Good job. So we'll stop the recording there. Next up is
So coffee
pastries.
break, everyone.